Hello, I'm Dr. Greg Pontone, and today I want to talk to you about anxiety, depression, and coping with multi-system atrophy. So, I don't have any relevant disclosures with commercial interests that'd be in conflict with the content of this talk. The objectives today will be to become familiar with the neuropsychiatric disturbances and multiple system atrophy, learn about evidence-based interventions for managing these symptoms, and discuss what you can do to maintain the highest quality of life possible while managing the disease symptoms. First, I like to start with a brief overview of multiple system atrophy. So this is a disease that has many disorders that are similar to it. It's in a family of diseases, and really the gold standard for diagnosis is still pathological viewing of the tissue. And so clinically, we do our best and get the diagnosis right the majority of the time, but the gold standard is still the pathology. And so because I'm going to reference that when I talk about these neuropsychiatric syndromes, I want to show you what I'm talking about specifically. So the family of diseases are the alpha-synucleinopathies. And what they have in common is that they have the same pathological substrate, and that's alpha-synuclein. And what happens in these diseases is that alpha-synuclein becomes misfolded. And when it's misfolded, it clumps together with itself and other proteins to cause abnormal aggregates. And these aggregates start a cascade within the cells that ultimately lead to cell death and dysfunction. And there are three main types of alpha-synucleinopathies. And these are the multiple system atrophy, the Parkinson's disease, or idiopathic Parkinson's, and then dementia with Lewy bodies, okay? Now, there are other little syndromes within there, but if you're a visual person, the way the Venn diagram of this family would look is that all of them are alpha-synucleinopathies, misfolded alpha-synuclein. But in Parkinson's disease and dementia with Lewy bodies and something called pure autonomic failure, the alpha-synuclein clumps together to form Lewy bodies, okay? Whereas with multiple system atrophy, the alpha-synuclein clumps together to form pap-lantose bodies, which are different. And they also tend to enter different cell populations. They enter oligodendrocytes, whereas most of the time the Lewy bodies are in neuronal cell bodies and cytoplasm. And so the other interesting thing is that in addition to having the commonality of this misfolded alpha-synuclein, these diseases often share Parkinsonism, which is a hypokinetic movement disorder. Some of them are levodopa responsive and some are not, or to greater or lesser degrees. In the people who have these motor symptoms, they're often going to have what's called a positive readout on a dopamine transporter scan or a DAT scan. And this represents striatal dopamine dysfunction. They often share autonomic nervous system dysfunction to greater or lesser degrees. And so there's also a clinical overlap besides this commonality of alpha-synuclein misfolding. And so just so you can see the spelling of this, these proteinaceous oligodendral cytoplasmic inclusions, it's pap-lantose. There you can see the spelling. They're in the cytoplasm and nuclei of both nerve and glial cells. So glial cells are sort of the support cells of the central nervous system. And this is rather than the Lewy bodies and Lewy neurites that are characteristic of Parkinson's and the Lewy body diseases. And so here on the left, you can see a slide of Lewy bodies and Lewy neurites, which are characteristic of Parkinson's disease. And then on the right, you can see the pap-lantose bodies in the multiple system atrophy cases. Very similar to Parkinson's, multiple system atrophy presents in the 6th decade. In fact, when I first started my clinical practice, we would refer to multiple system atrophy as Shy-Drager syndrome within Parkinson's, which was a syndrome of autonomic dysfunction along with the motor symptoms. So we use that eponym probably equally commonly with multiple system atrophy. And now, as you know, multiple system atrophy is recognized as a variant atypical Parkinsonism that has at least 2 subtypes, a Parkinsonian subtype and a cerebellar subtype, depending on the clustering of symptoms. But they have in common this progressive Parkinsonism. In some cases, profound cerebellar dysfunction, that'd be the C type, and then autonomic dysfunction, which ranges everything from erectile dysfunction, urinary problems, orthostatic hypotension, gastric problems, vision problems. And then another interesting thing about multiple system atrophy is that while there might not be many distinctive structural changes, at least in early Parkinson's disease, in multiple system atrophy, you can often get this T2 hyperintensity that forms a cross on axial images that really reflects the degeneration of the pontocerebellar tracts. And some radiologist probably thought that this looked like a hot cross bun. So you can see the long arrow there pointing to the hot cross bun sign. And it's not specific to multiple system atrophy, but most cases, especially the cerebellar variants, have this finding. And although you can find it in some spinocerebellar ataxias and other conditions, it does occur with pretty high frequency in MSA. So another interesting thing to look for when diagnosing it. But as I said, the gold standard remains the pathology. So now let's move into the main content of what I came here to talk to you today about, and that's things like anxiety and depression, and I'll talk briefly about psychosis and cognitive impairment in multiple system atrophy, and how it impacts the disease, and then hopefully deliver some good news that while the disease itself has to be managed, these symptoms are definitely addressable. You can improve anxiety, you can improve depression, and significantly improve your quality of life when these symptoms get better. And so the first thing you should know is that these symptoms, anxiety and depression in particular, are very common in multiple system atrophy. In fact, across all these related synucleinopathies, most studies show that dementia with Lewy bodies probably has the highest burden of neuropsychiatric symptoms, followed potentially by multiple system atrophy. So you're going to see these. Now, the types are different. And so that's what we'll talk about here is what can you expect? So one of the largest studies to date on these symptoms in multiple system atrophy has been done in a Chinese population, and they managed to get 237 individuals with multiple system atrophy. And they found that 62% of them endorsed significant depression, while over 70% had anxiety. And they did correlational studies and found that depression was associated with longer disease duration and greater disease severity, along with lower education. And then in anxiety, very similar, they found that longer disease duration and greater disease severity, along with orthostatic hypotension, were associated with anxiety. So the message here to me is clearly these symptoms are linked to the disease itself. They're either directly mechanistically linked, or in some way there's overlap between what causes the multiple system atrophy symptoms and what causes depression and anxiety in the brain. And so, this is important because when you're suffering from depression or anxiety, sometimes you're blaming yourself. You're wondering, am I just not handling this well? Am I weak? Am I giving up? Am I not fighting hard enough? And that's not the case at all. This is as biologically based as any other symptom you're having. And hopefully I'll go on to persuade you of that as we continue this talk. So let's talk specifically about depression and multiple system atrophy. So any depressive disturbance is characterized by 9 main symptoms. And most of the time, when people have 5 or more of those 9 symptoms for a prolonged period of time that interferes with their ability to function on a day-to-day basis, they're considered to have a major depressive disturbance, okay? Now, in diseases like multiple system atrophy and that whole family of diseases, Parkinson's, what have you, there can be some sort of crosstalk between what the disease symptoms are and what's major depression. And so being able to sort of sort these out and make the diagnosis of depression so that you can start the appropriate therapy can be important. And so I'm going to tell you about this with the hope that you can work with your doctor to make sure this isn't missed if you're suffering from depression, because it's going to require treatments that are different from those that are used to help other symptoms in multiple system atrophy. In fact, one of the most popular antidepressants, Prozac, had a formal randomized controlled trial in multiple system atrophy. And they found that while it did help with some of the emotional symptoms, it didn't seem to overall help the multiple system atrophy. And so it's going to be really important to distinguish the two syndromes, the movement syndrome and the neurodegenerative syndrome, from the depressive disorder. And so depressed mood is, a pretty intuitive symptom. You think if you're depressed, you should be sad. Well, it turns out that many people don't experience frank sadness. It may or may not be there, but pay attention to it if it is. Now, one of the confounds is that often people with any type of Parkinsonism, whether it's multiple system atrophy or Parkinson's disease, will have that sort of masked face because of the disease. And so people might observe them to be quote unquote sad, even when their mood is perfectly fine. And so again, take the time to think about whether you feel frankly sad and whether it's relevant and valid, because there are plenty of things to be sad about in life that don't mean you have a depressive disorder. So, sadness is a normal human emotion. It's only when it's overwhelming and persistent and, not bouncing back to normal, in the normal course of life events. Now, the other one that's a little more, I think, specific is this lack of interest or participation in your usual activities. And this can also be experienced as a lack or diminished pleasure in the things that you usually do. And so, even if someone's saying they're not sad, if they're withdrawing from their usual interests or participating in them less or deriving less pleasure from them, this could be a clear indication of a depressive disorder. The other thing about depressive disorders is that they're not just about your mood. They change all of your sort of innate drives can be diminished. So your drive for sex can be diminished. That goes sort of along with pleasure and interest in normal pursuits. But also your appetite can either be decreased, and that's the majority of the time people say that they have less of an appetite or they have to force themselves to eat. And they're often losing weight when this happens. Or, and this is more atypical, but it does happen, people will eat too much. And so sometimes you hear people say, I'm comfort eating. So you can have either way, but the majority of cases are usually a loss of appetite with weight loss. Now, sometimes when you have a neurodegenerative disease like multiple system atrophy, you'll have some wasting as the disease progresses. And this can be a little bit hard to discern what's depression and what's the disease. Disturbance of sleep. So this is another innate drive that's disrupted by depressive disorders, and it's part of the depressive syndrome. Okay. I often tell people that insomnia as a primary symptom by itself is actually fairly rare compared to things like depression and other disturbances that include disruption of sleep. And so most often in a major depressive disorder, it'll be loss of sleep, either having trouble falling asleep, waking in the middle, or what's called terminal insomnia, which is waking before you'd like to. So you say, I set my alarm for 7, but I wake at 5 and can't go back to sleep. And it's a repetitive pattern where your sleep is diminished. Now, just like there's atypical cases with eating where you eat too much, you can sleep too much. And so I'll see people who will sleep, 12, 14 hours a day because they're depressed. Psychomotor agitation retardation. So literally people, because they're depressed, their movement slows down, and so does their thought. And sometimes you can even, it's so profound that they'll have a speech latency. So you'll ask them a question, for instance, and the profoundly depressed person might have a delay where you could literally count 1,000, 2, 1,000 before they respond. And that's called speech latency. And so it can be really profound change in the speed of their interactions. Or they can be agitated. So you've seen the person who's, wringing their hands and distressed, maybe even pacing. So that's a form of psychomotor agitation that you can see in depressive disorders. Low energy. So, multiple system atrophy, Parkinson's are very fatiguing diseases, but low energy is also a symptom of depression. Diminished ability to think, concentrate, or make decisions. So oftentimes when people are depressed, they'll be very indecisive. They'll have trouble sustaining focus or concentration. Now, these last two symptoms are pretty unique to depression. And if you see these, those are a red flag that this person should probably have mental health care involved in their treatment plan. If people begin to feel hopeless or worthless or helpless or have inappropriate feelings of guilt, or in some cases, people will develop very morbid thoughts of death and dying, or even a plan to harm themselves, kill themselves, suicidal ideation. This is a clear signal that someone's suffering from a depressive illness and should get help. And so, again, I think remember, this isn't, feeling sad because someone's passed or you've had a bad life event. That's normal. It's this persistent low mood accompanied by these other symptoms. And you should really, at the very least, talk to your doctor about it. And hopefully you'll get the appropriate referrals to mental health care. Now, the other way this works, so I talked about you have the multiple system atrophy, and you're more likely to have depression and how these two things coexist. But now let me show you how they interact. So let's say you take a group of people who have multiple system atrophy, and one group is depressed and not treating their depression, and the other group is not depressed. Either they never had depression or they're treated and their symptoms are in remission. It turns out that your overall experience of the disease is worse for having the depression. So the depressive symptoms can make people perceive the severity of their, for instance, orthostatic hypotension as worse than it actually is, even when the actual objective measured drop in blood pressure is the same. The people with the depression are suffering more with the same severity of symptom. And they showed this not only with the orthostatic hypotension, but across a range of autonomic symptoms. So lightheadedness, faintness, problems with vision, weakness, fatigue, trouble concentrating were all rated as worse. That's the dark bars in the depressed people with multiple system atrophy compared to the non-depressed holding other symptoms equivalent. And this is a really important message, because that means that depression should be a very big clinical treatment target in multiple system atrophy, because it's going to help not only the depression itself and overall quality of life, but it's going to change how you experience the symptoms of the multiple system atrophy and give you a better overall experience. And so how do you go about treating depression in multiple system atrophy? And I think this is really important. So there really isn't a lot of randomized controlled trials of treatments for depression specifically in multiple system atrophy, but in sister diseases like Parkinson's disease, there's been some good work. And in the sort of general non-MSA population, geriatric, sort of age-matched population, there's good evidence for what works. And so the first thing that is pretty universally agreed on is that you want to have some type of behavioral activation, exercise, for instance. It seems that staying active and engaged universally helps lift mood, and later I'll show you decrease anxiety. So the other issue here is that exercise helps your Parkinson's symptoms within the multiple system atrophy. And so exercise is a clear starting place. In fact, you should be doing that as a matter of course with this diagnosis, but it's going to help your mood as well. Okay. Then, if you have a depressive disorder, you really should decide, am I going to take a medication or am I going to pursue talk therapy? And it turns out that at this first level of intervention, they're nearly equal in terms of their efficacy. So cognitive behavioral therapy is probably the one with the best evidence. And this helps people take distorted, depressed thoughts like I'm worthless or no good and recognize them as distorted, and then institute behavior changes that lead to better outcomes and ultimately will lift mood and change behavior. Okay, so very effective. Some mindfulness-based therapies do similar things in a less methodical way, but they teach a similar idea that you should recognize maladaptive bad thoughts and let them basically pass by you and not change your behavior, not distort your behavior. And there's good medication therapy. So remember, I said this is biological. This isn't like you've fallen down and aren't coping adequately. This is, a chemical change in your brain that's causing you to be stuck in this low mood with all these symptoms. And so selective serotonin reuptake inhibitors, medications that selectively target norepinephrine, a number of antidepressant medications that have different mechanisms have good efficacy, okay? They're going to work about 60% of the time, okay? Now, you have to take them for weeks before they really do their best work, and you have to be at the appropriate dose. And so I always tell patients, if you take these for a few days or just a week or two and you tell me they don't work, I'm going to tell you weren't on them long enough and you probably didn't achieve a high enough dose. So if you're going to try medications, make sure that you're committed to giving it, 4 to 8 weeks at an appropriate dose. They work slowly, but when they work, it's a game changer because it pushes these symptoms into remission and you have a much better quality of life. Now, let's say that you try either the therapy or a couple of these medications and they don't work. That's not uncommon. Like I said, only about 60% of the time is the first thing you try going to work. Well, then you move on to tier 2, okay? And in the second tier, it's when you might start combining some of these antidepressants, or you might combine the antidepressants with the CBT very rigorously. You might start augmenting with other medications. And I won't go into the specifics of these medications. This is really the specialist, but sometimes you'll use mood stabilizers. If for some reason you're having other problems like hallucinations or whatnot, you might actually use a low dose of an antipsychotic medication. And there's very specific ones that you use in diseases like multiple system atrophy. In some cases, in people who have motor Parkinsonism, adding a dopamine agonist, particularly the new generation, can be very helpful. Monotherapy with benzodiazepines, and you have to be very cautious because these can increase your risk of falls, can sometimes be helpful, especially in the short term. If you fail that, then you're really stacking medications. And again, this is not uncommon, but we always try to intervene in a way that minimizes your exposure to medications. But I just wanted to show you that there are very sophisticated ways of addressing depression that have good evidence and a long track record of helping people. And even though these studies weren't conducted specifically in multiple system atrophy, many of them were conducted in sister diseases like Parkinson's disease and are shown to be safe and effective. Now, another syndrome that's pretty similar to depression in some ways, but probably different in terms of the biological mechanism and therefore probably requires different treatment, is apathy. And so I want to just talk about apathy because it turns out that studies show that apathy might actually be more common in multiple system atrophy than it is in Parkinson's. And, because it's a syndrome experienced by the individual, the more knowledgeable you are, the better able you will be to discuss this with the people taking care of you and, get the right treatments. And so let me show you what I mean here. about the similarities and how to distinguish apathy from depression. So apathy is sort of this amotivational state where you lack initiative and the interest in doing the things you usually do. But unlike depression, you're not necessarily going to have any negative or positive thoughts. So you're not going to feel worthless or hopeless or guilty. You're just going to feel sort of indifferent. Okay. Now, you might be frustrated, but apathy really lacks these. And so while both are going to have this loss of pleasure called anhedonia, low interest and energy, maybe being withdrawn or indifferent about the things you usually do, you're not necessarily going to hear this complaint from the patient themselves. Most often it's the family or the spouse or a caregiver who says, they don't seem distressed, but they're not doing anything either. And so the reason it's important, and I wanted to talk about this, is that antidepressants really, and this is across populations, not just in multiple system atrophy or Parkinson's, but across populations, antidepressants really are not that efficacious, maybe not at all, for most cases of apathy. And so some studies show that another type of medication that's not an antidepressant, there are a class of medications called acetylcholinesterase inhibitors that are often used for cognitive issues, can be helpful in some cases of apathy. And then in some types of Parkinsonism, like Parkinson's disease itself, and maybe in multiple system atrophy, dopamine agonists might be efficacious. So again, I don't want you to worry too much about these specific treatments. I just want you to know that it's important to distinguish apathy from depression, because apathy can happen in up to 60% of people, more than 60% of people with multiple system atrophy, and that the treatments may differ, but there are treatments that might be helpful. So now let's shift from depression and apathy to anxiety. So anxiety and multiple system atrophy is interesting because you're probably vulnerable to all the normal types of diagnostic and statistical manual anxiety. These are the sort of classic psychiatric anxiety disorders like generalized anxiety disorder, panic disorder, social phobia, specific phobia. You're vulnerable to all of those. Maybe you have an increased vulnerability, so you get them a little more than people who don't have multiple system atrophy. We're not sure. But in addition, sometimes the autonomic symptoms, the autonomic nervous system dysfunction that you experience because of the multiple system atrophy is also experienced as anxiety or triggers anxiety episodes. And this has been shown. Things like difficulty with thermoregulation, the low blood pressure, the hypotension that we talked about, and other autonomic symptoms might be experienced as anxiety or might trigger anxiety. And there's been a clear correlation between autonomic symptoms and both Hamilton anxiety disorder assessment and Hamilton depressive disorder assessment in these symptoms. So most specifically in multiple system atrophy, postural blood pressure changes and beat-to-beat variation on the EKG have been associated with the experience of anxiety. And so, I just want to say that this might be part of the reason that 71% of people with multiple system atrophy experience anxiety, because it might be linked to some of the same mechanisms that cause the autonomic nervous system dysfunction. Another type of anxiety that we see in people suffering from Parkinsonism is what we call anticipatory anxiety. And it turns out, and I'll talk about this a little later, is that executive dysfunction is pretty common in multiple system atrophy and a lot of these Parkinsonian syndromes. And people like this will have an upcoming trip. Maybe it's a vacation that they'd otherwise enjoy, but for a month before, they're worried about the logistics of travel, and they can't seem to allay their anxiety, and they just keep worrying and worrying and worrying about this event in the future. How am I going to get there? How am I going to get through the line? What if the security people make me take off my shoes? Where are the bathrooms? And so it turns out that this type of anxiety might be associated with changes in cognition. And not that it's that common in multiple system atrophy, but it's more common than in people who don't. And it turns out that having mild cognitive impairment might increase your risk of this type of anxiety. And then another type that's specific to people who are being treated with levodopa, dopamine compounds for their movement, is this fluctuation associated anxiety. So normally, we give you, for instance, Cinemet or a levodopa compound, and it's absorbed by your body, and your motor symptoms usually get at least a little better. But then as it wears off, the symptoms come back. And during that same period, as it's wearing off, many people experience anxiety. And in Parkinson's, they actually were able to show that if they give people levodopa infusions, increase their brain's dopamine, their anxiety decreases. So clearly there was a correlation between anxiety and dopamine levels. Well, they've done the same thing. And this table that I'm showing you, this figure is from Parkinson's population, but they've done a similar thing where they've shown that anxiety can be levodopa responsive in multiple system atrophy as well. I've included that reference at the back of this talk, but the importance of this is that if you notice that your anxiety is cycling with the timing of your medications, maybe as they wear off toward the end of dose or in some other way, this would be important to recognize so that you could share with your treating doctors so that they could help you, because this type of anxiety might be best addressed by giving additional levodopa or dopamine compounds. And then finally, and this is a big one, is that once your disease has progressed to the point where you're falling frequently, many people develop a fear of falling, and they'll start walking less, become less independent, maybe avoiding things where they know they have to walk certain distances. They're freezing more frequently because of this anxiety. They're having more turn hesitation compared to people, even with the same number of falls, who don't have this fear. They're walking slower. So addressing this type of anxiety is really, really important, because you become more disabled more rapidly when you have the fear, even if the rate of falling is the same. And so most often this type of anxiety is best handled by behavioral interventions, okay, working with a physical therapist, an occupational therapist, doing what's called exposure therapy. So literally making you walk and then troubleshooting the anxiety using cognitive behavioral techniques so that you experience the fear, which is valid. You're worried about falling and the consequences of falling, but then overcoming it so that you can maintain your independence. So I think this is a really important distinction and a type of anxiety that is specifically found in diseases that affect your ability to walk and maintain your balance. And so, again, I just want to show you this sort of algorithm that we've developed. Mostly, it was mostly targeted at Parkinson's, but it's relevant to multiple system atrophy. And it's this idea that first, let me know the type of anxiety. Is it related in any way to the multiple system atrophy or its treatment? So for instance, is it fluctuating with the timing of your dopamine medications? Is it related to a fear of falling? Is it maybe due to some cognitive impairment, okay, so that you're not able to go through an upcoming event and allay your anxiety? Or is it clearly happening when you're having other autonomic symptoms, whether they're gastric symptoms, whether they're symptoms of change in blood pressure? Because that's important, because if you try to target this anxiety using a generic approach, you're probably going to be less successful. So that's the first thing we recommend, is that you sort of take a qualitative look at the anxiety and see if it's associated with any of these disease symptoms. Now, let's say it isn't. Let's say that it's just a panic disorder that anybody could get with or without multiple system atrophy, or a generalized anxiety that people get all the time. Then, again, I hope you see that exercise is the first thing you should do. You should mobilize yourself, because it turns out that physical activity, your favorite exercise, and it's probably that cardiovascular exercise is the most helpful, helps mood, whether it's depressed mood or anxious mood. And it also helps cognition, and I'll talk about that in a minute, probably as much or more than any of the medications that we have. So you should be doing that, plus either taking a medication, and these are many of the same medications that I talked about as antidepressants. So they're selective serotonin reuptake agents or selective norepinephrine reuptake inhibitors, or cognitive behavioral therapy or mindfulness-based therapies that include an element of breathing control can be very helpful, because anxiety is often a autonomic arousal syndrome. And so whether it's caused by the autonomic arousal directly or triggers autonomic arousal, learning ways to decrease that arousal will decrease the anxiety as well. So whichever you choose in tier 1, if for whatever reason it's not successful or only partially successful, we move on to tier 2, which is when we start combining elements of tier 1. So we might be doing 2 medications or 1 medication plus cognitive behavioral therapy. And again, it's not important that you know what these individual elements are. I just want to reassure you that there is a structured approach for helping anxiety that is successful in the majority of cases in decreasing the anxiety. Okay, and I just want to give you a way to think about this so that when you partner with your doctors, you know what to ask for and how to assess your own symptoms so that you can convey them to the doctors and nurses and people working with you so they can help you. Now, I want to talk about cognitive impairment and multiple system atrophy just briefly, and I want to do it in a way that compares it to other Parkinsonian disorders so you could have some context of the severity and how it goes. So it turns out that mild cognitive impairment, so this might just be, in most cases, executive dysfunction, so greater difficulty in our ability to organize, sequence, or plan, is pretty common. And it happens in at least 40% of people with neuropathologically confirmed, remember seeing those Paplantos bodies and other changes, MSA cases, okay? That's pretty similar to other diseases in this family. So Parkinson's disease has about 40% of people with mild cognitive impairments, and they are predominantly in the executive function domain. Now, what's interesting is it does seem, and this literature's growing, it does seem that severe cognitive impairment is rare in multiple system atrophy, where it's actually pretty common in Parkinson's disease. So maybe in one study of pathologically confirmed cases of multiple system atrophy, it was only 7.4% compared to more than half of people with Parkinson's disease end up having severe cognitive impairment. And so it takes a while to develop, but again, this is at least one case where this type of symptom seems to be less pronounced in multiple system atrophy. Now, while I said, frontal executive function is the most likely to be impaired, sometimes memory and attention can be spared, or they at least tend to be most preserved. Okay, and so this is sort of a reassuring thing. Psychosis. So psychosis is something that, again, won't be as pronounced in multiple system atrophy. In fact, if you see that early in the disease, broaden your differential, because now I'd worry more about things like dementia with Lewy bodies if I see it early. So it's actually thought to be pretty rare. I'm not saying it doesn't happen, but compared to dementia with Lewy bodies, Parkinson's disease, it's much rarer in MSA. And in fact, in a small study of pathologically confirmed MSA, only about 9.5% of people had hallucinations. Whereas if you look at a similar population of people with Parkinson's, 50-60% of them are going to have some sort of hallucination over the disease course. And so again, while there are many burdens and challenges of multiple system atrophy, these two symptoms seem to be less prominent, which is you got to catch a break somewhere. And so now let me shift gears a little bit. So I've talked about what can go wrong in the disease, but now let's talk about a more positive approach. And I think this is true. I think people, the Western medicine has really focuses on the sort of distance between the illness and getting back to normal daily function. But really, we should be considering how to be well, not just survive, but thrive. And so I want to talk about this whole spectrum, from being, suffering the worst symptoms you could, to getting over them, to thriving. Okay. And I think when you have a neurodegenerative disease, a progressive disease that's going to be chronic, whether it's diabetes or Parkinson's or multiple system atrophy, you really have to have a positive mindset, because you've been given this burden and it's unfair and most of your peers don't have it, and you wake up with it every day. But in order to have the best quality of life and to remain a part of your community and family, you really have to have this philosophy of striving for wellness, for, being the best you can be despite your burdens. So what is wellness? Okay. A lot of times wellness, if you watch commercials, is a spa membership and the $10,000 a year tennis club participation and massages and cucumbers on the eyes with your facials, right? It's not what wellness is, at least not what the World Health Organization defines it as. And they, let's start with health. What does it mean to be healthy? And it's a state of optimal well-being, not merely the absence of disease or infirmity. So that's sort of what I was telling you by, hey, I think most of medicine sort of stops here, right? You got a symptom, let's make the symptom go away. But that's not really thriving, right? That's just, hey, I had pneumonia, I had COVID, and I lived through it. That's only here. We want to be up here, all of us, right? Regardless of what we have. And so wellness is the active pursuit of activities that we enjoy, of choices that make us the best person morally and ethically and within our community and family, and lifestyles that lead to a state of health. So being physically active in a structured, rigorous way, not just because your doctor said to, but because it's a part of your lifestyle. Eating the right things, making, food almost a ceremony of living. I'm not just eating because I need the calories. Like, let's do it in a way that I enjoy. So the Japanese culture has a seasonal philosophy about food, and it's beautiful. And there's rituals around how to eat foods together in combination. And so I think, this is, other cultures have these beliefs. And what I'm saying is, let's bring this to, diseases and not just aim at resolution of symptoms. And so here's an actual diagram that was developed by Dr. John Travis. He's sort of the wellness guru in the Western world. And you can see that this is his conception of health. It's not just preventing death and going to this middle state, the neutral point he calls it, where you have the absence of symptoms. It's going beyond that to an awareness of your body and your symptoms and their absence, educating yourself, growing and overcoming till you have a high level of wellness and you're actually enjoying your life despite what you can't do. Like, let me tell you, I'm never going to be a professional basketball player, but I still manage to enjoy the rest of my life. So there's things as we all age, as a natural course of our life, that we have to leave behind that may have been goals at some point, but are not attainable now, or not realistically attainable now. And so all of us have to leave things behind, and people who are burdened by chronic disease may have to leave more things behind, but it doesn't mean that they can't still strive for a higher state of well-being and quality of life and the things that are still achievable to them. Okay. And it might be different things. Okay. Just like, aspirations you had early in your life might not be achievable now. So you switch to other things. Maybe you emphasize family more and connectedness or intellectual pursuits. And then, so finally, I think the last message I sort of want to leave you with, because one of the biggest barriers we've seen, regardless of whether it's multiple system atrophy or what your disease is, when you have a mental health concern, people feel stigmatized. They feel as if they're crazy and that somehow they've dropped the ball and they've not coped, and it's a foible or a character weakness rather than a biological illness. And so I think, unfortunately, a lot of this stems from Rene Descartes' what we call Cartesian dualism, where he sort of saw the mind as distinct from the brain and body. And today we know that's not true. that, the brain secretes the mind, if you will. The mind is a product of the way our body functions and our brain functions. If the healthier your body is, the healthier your mind will be. And that's why exercise is such a core component of health, because these don't exist in a vacuum. Your brain is at its healthiest when your body is healthy. And so when you're suffering from a disease, you really have to fight mentally and physically against the disease. And so in the same way, if you sort of embrace this idea that the mind and body are not separate entities, you should also be able to leave the stigma of suffering from a mental symptom behind. Because if you can say, hey, I have no shame in the fact that my blood pressure drops 40 points when I go from sitting to standing because it's caused by multiple system atrophy and neurological disease, you should also have no shame in saying, my mood is stuck in a really sad state because I suffer from this disease that changes the chemical levels in my brain. And that's essentially what this is. And so really what I want you to do is think of this as all part of the same challenge, and strive to not only push these symptoms into remission, but to thrive and aim toward the best quality of life. And this is something that I think we all have to do for different reasons. And if you can engage your care team in this goal, I think you're going to have the best possible outcomes in life, regardless of the challenges the disease brings. So anyway, I'll stop there, and hopefully this has been helpful. And if there's any questions, I'll try to field them in the Q&A session. Thanks for your.
Great, thank you. Seeing a couple of these, I'm Erin Williams, and I'm going to be helping facilitate some of the questions here. I'm not sure if you want to jump in, Doctor, or not, but so one of the questions I wanted to, address is how do you get motivated to do aerobic exercise if you have a fear of falling?
Yeah, that's a great point. I mean, motivation is, one of the things that can be affected if you have a mood or anxiety disorder. And so, a lot of times what we recommend is that people try to involve themselves in structured activities, because that creates an external pressure or accountability. And, for instance, let's say that you sign up for an exercise class, or you're participating in a physical therapy course. You're expected to be there at a certain time. And if not, you kind of disappoint the people you're involved with. And so sometimes that additional scaffolding, that social sort of pressure really helps. But then as you engage, you'll find that most people tell me that they enjoy the social contact, and they come to enjoy being around others and exercising. And so I always tell people that even if they've never been someone who's exercised in a group before, to seek that out, or to maybe even start using a trainer if they're not doing formal physical therapy. Anything that works.
Mm-hmm. Mm-hmm. Another one, can you address grief versus depression and how you can deal with that?
Yeah, so grief and depression, well, that's kind of tricky, because I'll tell you that especially later in life, you're going to suffer things that cause you to grieve. And grief is an appropriate emotion, and it's usually time limited, or at least its most severe part of the course is time limited. And so let's say, for instance, that someone close to you passes. All right. Or maybe in the case of being diagnosed, you're grieving because of the things you may lose because of the disease. That period really is not something that you necessarily need medications for. You want to express that grief in a healthy way. Ideally, you do that in the case of someone's passing with the support of friends and family who also knew the individual who passed. But look for things that would suggest it's more than just grief. So one of the things that we see when someone's suffering from more than grief is when they start to withdraw, when they start to do unhealthy things, or when they're no longer functioning in their normal day-to-day activities. And that's the sort of difference between the normal grief that we all have to experience when something bad happens and the transition to depression, which is actually a clinical syndrome that needs usually medications and care.
Okay, trying to speak louder. Is that better, everybody? Okay. I mean, there's been also just some comments from folks, and unfortunately not being able to see doctors other than virtually as of recent, and how difficult that can be. I agree with you, Doctor. As my mother used a trainer to work with her in her more for her last couple of years, and it really made a big difference. And we found that just at a local gym, and just sought somebody out, but that did make a big difference. Let's see.
Well, I do think that the comments that I saw too, though, about not being able to access doctors or care teams, especially during the pandemic, I will tell you that social isolation and loneliness have been big issues for many people with chronic diseases. Well, many people in general, but especially those who might have a disability that further limits their mobility. And what I would say is that you really need to find a way, a safe way, whether that's by Zoom or social distancing, to maintain social connectedness. They've actually started, and this will sound funny, but it's true, they've actually started to quantify the health effects of loneliness and social isolation. So they're saying that a certain duration of social isolation is the equivalent of smoking 15 cigarettes per day. They can show that. And I'm not talking just on your mental health. They're showing that your risk of other chronic diseases and mortality risk is the same as 15 cigarettes a day if you're not appropriately connected to others and feeling isolated and lonely. And so this is really a big issue. And I mean, I think I saw in the panel that they were commenting mostly about being sort of disconnected from their care team and doctors, but I think it's true, in terms of the community support as well.
Great. And someone was saying, due to their legs being, weak and balance is poor, getting dizzy, just other ways of exercising. I mean, I don't know about swimming in a pool. Has that, using obviously with somebody else, but has there been, this is pure suggestion on my end, but yeah, swimming, possibly doing that while you're in the water, and just using that as the ability to keep yourself more upright. That works for people who have other injuries as well.
Yeah. Seated exercises. So there's an entire sort of program of sittercise that we use in our groups. And, I have to tell you, honestly, they're really creative. There's even a type of almost a badminton with a balloon-like thing that we do that everybody seems to find really fun and engaging. And again, in groups, and then you add that social element that I think really elevates it, because it's kind of hitting, checking more than one box, so to speak.
And then another person asked about Tai Chi. Was diagnosed within the last year with MSAC, and looking to see if Tai Chi was something that would, great.
Yeah, a lot of those exercises, the sort of Eastern exercises, whether it's Tai Chi or yoga, what's really nice about them is they include elements of the mindfulness, which I think I did mention in the talk, has elements that are very similar to the most effective type of psychotherapy, which is cognitive behavioral therapy. So mindfulness, one of the things it teaches, besides focus and keeping out distractions, is identifying thoughts and emotions and then sort of keeping them separate, or at least learning to recognize them as separate things. And that's so key to managing your mental health. And when it's incorporated in things like Tai Chi and yoga, it can be incredibly helpful.
Persons are asking if you're currently taking new patients, doctor. I don't know.
Yeah, no, it's funny. I think fortunately our center is always open. The wait times can be significant, but we have we call it our atypical Parkinsonism center, and it's not just me. I think we have a half a dozen MD medical degree providers and a number of great nurse practitioners, and I think what I always tell people is right now you want to engage not only with your providers, but you really want to form bonds in your community. So if there are support groups for either MSA or Parkinson's, these are important too, because oftentimes you'll hear ways people are managing their symptoms that can help you at home. And we learn from our patients as much as we do from textbooks, right? Because we hear the way they're managing the symptoms at home, and then we pass that advice along to others. And so don't underestimate the importance of good community.
That's great. And similarly with caregivers, there's obviously a lot that you can do to support your not just the physical, that definitely getting out and physically supporting them so they feel comfortable enough to do some exercises of any kind. But how do you support a family member who's feeling depressed or anxious? How can one approach the conversation with their family member?
Yeah. So this, I think if I'm understanding this right, they're saying, how can
that they're the caregiver? Yeah, asking for some. Mm-hmm.
So this is something I definitely am glad was mentioned, because I want to put this on everybody's radar. There is an incredibly large literature, not just in multiple system atrophy, but in many chronic diseases, about how the burden of caregiving affects the caregiver, and then how now it comes back to the individual's care as well. And so it creates this snowball. So we have to do a better job of supporting the caregivers and family members as well, because it's, they care about their loved one and they can see things changing, and it might affect their mood. In fact, rates of depression and anxiety in caregivers is higher than in people who aren't giving this care. And so in the same way that I mentioned community is important for the person suffering from the disease, there are many caregiver support groups that are out there. And, I always tell families there comes a time when what you're doing is no longer a one-person job. And I think, unfortunately, that often comes before most people are willing to admit it's no longer a one-person job. And that's when we really see caregiver burnout and strain happen. And so I would say that from the beginning, once you recognize that you're going to have to provide care, you shouldn't assume or attempt to do it by yourself, even in the early phases when you can. You want to, at that point, develop a system for having more than one person rotate the care. Even if you could do it all by yourself early, you want to have that plan early. And then you also want to have an early conversation about when it becomes too much, what is the plan to transition? For some families, they can't accept having the patient outside of the home. So they want to have a plan of having in-home help. Some people can afford that, some people can't. Families differ. Other families are, when it gets to this point, we're going to outsource it. We're going to have an assisted living or something. But I think this is a conversation you want to have early. And the reason being is that when you have early in the disease, you have the luxury of options. Later in the disease can force your hand. And so I always tell people, do that planning as early as possible. Have that conversation the minute someone else has to help in the individual's care. And then that way you sort of get it out of the way, and that's less for everyone to worry about. And it's a hard conversation. It's hard to talk about. And the other thing I want to say, and I know this is more than the question that was posed, but everybody at the beginning of the disease has one idea of what they're willing to tolerate or what the burden will be. And I can tell you, it almost never matches what ends up being the actual burden. I do this, I don't have the disease, but I can tell you that I've worked with hundreds of people who have the disease, and I can tell you that it's never a one-person job. And recognizing when that point comes is important for everybody's health, the caregivers, the family, and the person suffering from the disease. And so this is something you really want to talk to your doctors about, because they're going to help you navigate this. And I would say, don't wait until you have to. Do it right at the beginning, right? Have that conversation early so you can start steering yourself toward, in that direction.
Right. I believe do we have time to continue, or are we done at the time frame? I'm not sure.
We are out of time.
Okay, that's what I thought. Okay. Well, appreciate all the questions. I believe we can keep all of the chat, so at least, see if there's some other conversations that were not, or some questions that were not addressed. But thank you very much for Dr. Gregory, and for everyone who participated today.
Thanks for having me.